India is now in its second phase of lockdown, and the question remains the fundamental one. A lockdown may flatten the curve, but how sustainable is it in the long run? This is not a question just for Indians, it's a question for the world everywhere. The United States of America is grappling with this question as well. The Trump administration wants to lift the lockdown. It's the governors who are pushing back. The answer eventually has to come from science. But is science really telling us all that we need to know to answer this question? From New York today, we're joined by Dr. Siddhartha Mukherjee. He's an oncologist. He's also a Pulitzer Prize-winning author and a fine mind. It's really a pleasure to have him with us. Siddhartha, first, I just want to ask you to give us a sense of what's happening there. New York, in many ways, where you are, has been the epicenter of this pandemic in the United States of America. Does it look like the virus has peaked there, or do we not know the answer to that?
Well, it certainly seems that the deaths from the virus have peaked. The daily death count was in the 700s about a week ago, and the death counts are now in the 400 to 500 range. There is a suspicion that we're undercounting the deaths because there are many people who have died without a diagnosis. But even if you count those, I think there's a sense that it's peaked. Now, you know, one thing, I'm also trained as a viral immunologist. And one of the things about these viruses is that when you lift the lockdown, there is a distinct possibility that there will be a resurgence. So the idea of the peak is currently a temporary idea. I mean, we certainly have peaked, but whether that peak can justify the opening of New York City again is a question that you and I will discuss.
What is your own sense of that question? And I ask that because obviously different countries, different cities will answer that question differently. So let's start with New York first. Would you, if you were advising the governor, would you say it's time to experiment with easing the lockdown at least, if not lifting it?
Well, I think the governor has the right approach to this. He is going to do this in phases. The phase one may be lifting a little bit more than the essential workers. But scientifically speaking, we need a certain number of things to be true. Number one is that we probably need to triple or quadruple the number of tests that we're doing for people carrying the virus and people who are immune from the virus. Now, it's important to realize that there are two different kinds of tests and they give you different kinds of information. One test is the oral swab or the nasal swab, and that is a test that detects whether you actively have the virus or not. Are you in the middle of an infection, whether you're secreting or excreting virus, etc., and whether you're infectious. In those circumstances, the correct thing to do, of course, is to decide whether you want to be in quarantine or isolation, or whether you need acute medical care and go to the hospital for acute medical care. A second completely different, so that test has now gone through many iterations, the viral swab, and we think that that test is now accurate. There were some mishaps, as you know, in this country with that test. It came about 30 days too late, and 30 days for a virus that spreads so rapidly is a very crucial time. The second test is the antibody test. The antibody test tells you whether you've previously had the virus or not, but it also, the antibodies start rising while you might be having viral secretions. So if you combine these two tests together, you get three categories of people. Those who are actively infectious, those who are actively infectious but are developing immunity, and those who are no longer infectious, as far as we can tell, but have developed immunity. I think in order for any country, any state, these two tests are crucial at large scale to figuring out whether that can be opened or not opened. Because, just to give you one example, if we find that 60% of New Yorkers, it's not a lot, and this is a hypothetical number, if we find that 50 or 60% of New Yorkers are no longer shedding the virus but have already acquired immunity to the virus, then I think it's quite safe to open New York City. We still have to deal with what to do with people coming in. We still will have to use masks. But if we find that 2% of people in New York City are already immune to the virus, and 20% of the people in New York City are actively shedding the virus, then of course it is dangerous to open the city, because that will cause our healthcare system to collapse.
But Siddharth, India hasn't even begun the antibodies tests yet. I know that there is a waiting line for the kits, and we're waiting to start that. Would the answer then be random testing and then random sampling? Because without that, you can't actually test every single person or even 60% of New York or New Delhi.
That's right. So I think random testing does have a role in this, because I think the most important thing which Kerala has done and which other states are now doing is to be driven by data and not by emotions. Mm-hmm. And the data is supplied by a combination, as I said, of the the nasal swab, and the antibody tests. I think it's important to be driven by data and not be driven by emotions here. There's a lot of science behind all of this. I also have really quite a strong message of hope, which is that drugs are in development, antibodies are in development, and vaccines are in development. They just need time. This is the fastest anyone has ever worked to develop these medicines, and scientists and physicians who are really, have been heroic in their efforts to do this. But we have to be data-driven. We can't be emotion-driven in this. And the more data we have, the better it is.
Can you tell us in simple terms, without being inaccurate, where we stand on the medicines? We do know about the vaccine. It needs time. There are trials that have begun. We saw that announcement from the United Kingdom today. But where do we stand on the drugs? Because there's been such conflicting science. In India, for example, people do continue to treat patients with hydroxychloroquine and azithromycin. It's an experimental approach, but it's in the absence of clarity on what else to do. Now there is talk of blood plasma as a possible approach. What do we know and what do we still not know?
So drug development and vaccine development proceeds in stages. The first drugs that are likely to be effective for SARS-CoV-2 are drugs that are repurposed. And by that I mean drugs that have already been used in humans that are now being repurposed or reused in this context. And of course, hydroxychloroquine and azithromycin fit into that category. The data that we have so far, and in fact, there was another piece of data from yesterday, is that at least in moderate to severe patients, and perhaps even in less moderate patients, this drug combination does not seem to be very effective. There is a second drug called Remdesivir, from Gilead Pharmaceutical that is going through very active testing. 2 articles have been released on it. It seems that we still don't know whether it works or not. It needs to be fully tested. And those tests, the first of those tests, will come in late April. But it is a promising drug. It has been used before in other viral infections. In animal studies, this drug seems to work. Whether it works on severe or moderate or prophylactically, we don't know. The second set of drugs that is so that brings us up to April, early May. And that will really change the game. I think the presence of a drug will really change the game. So I'm just going in an orderly progression. The third set of drugs that are likely to come up are antibodies. Antibodies are made by cells, and so it's not easy to produce them. As you might know, Kiran Shaw from Biocon and I have been in extensive negotiations with various companies because we have, Biocon has the capacity to produce these antibodies. And so we are trying to get these antibodies produced. But of course, long before their production, they have to run through the same kind of clinical trials that any drug has to run through. But there's a lot of promise in them because, exactly as you pointed out, in a very small case study, when people who had already had recovered from SARS-CoV-2, when their antibodies were given to people who had the infection, the patients recovered. That would suggest that the antibodies are active. We just have to make those antibodies, the naturally occurring antibodies that happen in human. So that brings us out to June and July at least. It takes a while to produce them, and we don't have a lot of capacity. The whole world doesn't have a lot of capacity. These are made in swimming pool size flasks, which have to be kept clean. This is a big project. Finally, we come to the last two categories. New drugs, drugs that we invent from scratch. Those have to be tested first, of course, to make sure that they're not toxic, because human beings have never been tested on these drugs. That already brings us into September, October, and then the production of those drugs. And vaccines. Now, the first vaccines, as you very well know, have gone into humans, both from the Oxford group and from Moderna and from a whole bunch of other groups. Vaccines have the following problem. They're the best, they're the most effective, but there are two issues or three issues with vaccines. Number one is, in the case of a vaccine, you're giving it to a healthy person. So you have to be extraordinarily sure that it is safe, because you're not giving it to a diseased person, you're giving it to a healthy person. Now, that's number one. Number two is that they take a long time, because if you have a patient who's already infected with the virus, then of course you can test whether the patient is getting better or getting worse. When you do a vaccine trial, you have to test whether, if you randomize it, you have to test whether a random group of healthy people are getting more infections compared to those who didn't get the vaccine. And you can imagine that's much, much longer, much more complicated. And finally, vaccines have production issues. You have to produce, several billion doses if you really want to vaccinate a large percentage of the people. So for a vaccine, at the most, optimally, we're looking at, at the fastest we could do is October, November, possibly a little bit longer than that. Most vaccines take about 12 months.
So drugs and the physical production of antibodies seems to be, if all goes well, a faster timeline than a vaccine.
That's right. But also remember that drugs, the antibodies, unfortunately, are both the drugs and the antibodies are for therapeutic use. They're not for use to prevent the disease. And obviously, if we could prevent the disease from happening in the first place, that would be the best thing to do. Right now, none of this is in play. Right now, what we have in play is exactly what, as you said, the state of Kerala is doing: isolation, testing, and quarantine, possibly lockdowns, and the lifting of lockdowns in a data-driven manner.
Now, in India, as you know, there is a different debate than in other countries, because it really is about, lives and livelihoods. And there are any number of poor people that I have met. I have walked with migrant workers as recently as yesterday. They're still walking the expressways of India, wrenching open our class differences and our class divide. And so many of them just say one thing: the poverty will kill us before the virus. What are the ethical questions before a country when it seems that a lockdown hurts the poor in ways that the middle class, the upper middle class, and the wealthy cannot even begin to feel?
Well, this is an incredibly important question. In fact, it's a question that all countries are answering. Of course, it's most acute in countries like India. And there is some truth to the fact that poverty will kill as much, or if more, than the lockdown. So I think there is a great urgency to be sensible about this, and there's a great urgency to be thoughtful about this. I mean, putting people in camps during a lockdown makes no sense, because they are under no physical distance whatsoever. I'm a big believer in low-tech solutions. I think masks work. If we can get enough soap and water, those work. I mean low-tech masks. I mean a T-shirt folded over twice with a rubber band, and you can find many examples of how to do this. I would release several public service announcements in India to show people over the internet, over their cell phones, about how to do this. But you're right, the crisis of the migrant workers is enormous. We don't even really know what the extent of the spread is without testing. So once again, there is something to be said that poverty will kill as much, if not more, than the virus will kill. And so this is a time that as I said, a strong bipartisan effort to try to get a message across and figure out what to do with migrant workers, whether they can be socially distanced, whether we can provide them with enough food, whether the state can step in and provide them with facilities or places that they can actually rest while they move in a manner that is compatible with not spreading the virus is of crucial. I don't know, but Barkha, is there a task force that's been appointed to take care of the migrant movement in India?
So governments have been trying to discourage the movement, and it's not working. It's actually not working. In the first aftermath, there were buses arranged after 72 hours of them walking. Then there were orders to not allow them to move, and there is no bipartisan agreement on this issue. There are chief ministers who say send them home because it is it's not practical because we don't know how long this lockdown will last. They're not getting wages. The biggest problem is their daily wages and they don't get paid. And like every human being in times of crisis, they want to be home. And also, we've chartered buses for students, we've chartered airplanes for stranded Indians. So there's that sense of why can't we send them home? The counter argument is the virus could move with them. So nobody has easy answers to this. And it really is a moral dilemma for the Indian state.
Well, so, as I said, one approach would be to appoint a task force. The ICMR is very thoughtful about this. Health ministers in states that have been successful, such as Kerala, are very thoughtful about this. And, one possibility is to appoint a task force, really start random testing, either using the serology or the nasal swab, to figure out what the real incidence is, and then advise, as I said, the lowest tech solutions, which are social distancing, mask wearing, and hand washing at this moment. There is no simple answer to this question. Yeah. It is a tragedy beyond all proportions.
And the other tragedy that I see unfolding, Siddhartha, on the ground is what happens to non-COVID poor patients. So most of them can only get medical treatment at our public hospitals. Many of our public hospitals have become COVID-only facilities. So you go to these hospitals and you find tuberculosis, cancer patients actually being turned away at the door. I have personally now reported 2 deaths that have occurred just from not being able to get medical intervention in time. And the data, 1,300 Indians die from TB every day, as many die from cancer every day. There is a worry in medical circles here that in our preoccupation with the COVID-19, what happens to all these other people? What happens to other diseases?
Well, so again, it's important to be data-driven. For reasons that we really don't understand, the number of COVID deaths in India has been disproportionately low compared to many other countries. And we don't know why. There's lots of theories. And none of those theories have been proved. But nonetheless, if the deaths were really occurring at the rate that they're occurring in New York City, you can't hide 10,000 or 100,000 bodies. Even if you do testing or you don't do testing, when people start dying en masse, you cannot hide that fact. So I think that I think this is why an India-specific task force would be very important. I know that there are many at the state level, but this has to be a central level task force. And I was reading, and I read extensively, the extent of help given to the people who earn daily wages seems to be disproportionately low. And so therefore, it seems to me that such a task force could open up a whole series of movements, including finding ways to get these people to the places that they need to get to faster, so that they're not stuck. Being stuck in a migrant camp with no social distancing, no masks, and no testing seems to be worse than being stuck either in the city or in the destination home by far. And it will likely create a nidus for the virus. And what we want to do right now is exactly not that. If there's anything that we want to do right now, it is not to create a nidus for a country where the infection rate, for reasons that we still don't understand, doesn't seem to have peaked.
So two things. There is a national COVID task force, but it's not really looking at the issues of either the migrant workers or the non-COVID poor. So that's something that may need either attention within the same umbrella or under a different sort of banner, as it were. My second question would be, what do you make of the fact that India seems to be an outlier? There are people here who are arguing that we just won't know till we test more, or maybe we still haven't peaked, or maybe if we're lucky, we are the outliers. But do you have any understanding of why this might be?
To be totally frank, I don't. And to be totally frank, the world doesn't. There have certainly been cases that have come in from workers from India who were in Wuhan and other places. And so we understand those. They came into places like Kerala, as you know, and they were quickly isolated and quarantined, and they have now, as far as I know, recovered from the infection. There is the possibility that there is not so much travel between infected countries and India, but even that seems to be a little bit of a remote possibility. There has been the idea that it's the temperature, the idea, although that doesn't seem to be totally, that doesn't seem to totally make sense, because in February, when I was in Delhi, it was just about as cold as it was in any other part of the world. And other parts of the world that are warm, like Brazil and the Southern Hemisphere, have also had outbreaks of COVID. So it is really a mystery, I would say. Part of the mystery is that we aren't doing enough testing. If we tested more, we would know the answer. But as I said, you can't hide 100,000 dead bodies. And so there is certainly a mystery, and the world doesn't know the answer.
Finally, the CDC I saw was talking about a possible second wave of this virus by winter, one that it said might even be worse. I was reading that in the Washington Post. Now, if we do not, a vaccine will take time. If the drugs don't give us the message of hope that we need, countries cannot permanently remain in lockdown. And we are having pushback from many people within India, at least, saying, start lifting the lockdown, create zones, allow some zones to function, maybe tell people to wear masks, take other precautions, maybe change ourselves in behavior and the precautions we take rather than shut down the country. We've also had a more draconian lockdown or a more absolute lockdown than other countries. For example, we do not have public transport except for a skeletal bus service, unlike other parts of the country which has kept public transport open. Our aviation is totally shut. The Indian Railways is not running. So we're a unique country in that way. So the lockdown also hits us harder.
I think it makes a lot of sense to lift the lockdown in phases. And I think it makes a lot of sense. I mean, it's impossible to anticipate the winter, and it's impossible to anticipate a second resurgence of the virus. We need to do the best we can. In the United States, this is a big worry. We're also doing the best we can, but the best we can may, again, will be determined by what actually happens. I happen to hope that the drugs will be available. We have, in our negotiations so far, and as I said, I'm not the only person in this negotiation. There are many, many parties, many, many individual parties. The general agreement has been to sell the drugs in India in a way that just recovers the cost of making the drugs with a little bit extra, so that we can provide the royalties or licenses back to so this is not a profit-making enterprise. And we are very committed to doing that, but it will take time. I think that once the fear of death is removed, and that, that this turns out to be obviously a difficult disease, but the fear of death is removed, I think the economy can be, and the lockdowns can be lifted in a phase-wise manner that is more conducive to an economy functioning back. I mean, a functional economy is the creative life of humans. You cannot, and the shift from peril, from precarity to outright peril has become very obvious in all countries, but especially India. We need to stop that. And so again, data-driven, phase-wise lifting of the lockdown in a very non-emotional manner, especially with low-tech solutions to start, and then moving on to drugs and vaccines seems to be the right thing to do. Unfortunately, Barkha, there's no quick answer. This will have to play itself out, but those are the best answers that we have.
Okay, thank you, Siddhartha. That was very educative, very informative. I'm hoping to bring you back next week with Kiran Shaw. I know both of you are doing a lot of work on this together, so let's hope we can have that very important conversation, because it's important to keep politics and emotion both out of this conversation in India and keep it as science-driven as possible. And thank you very much. Thanks, Siddhartha.
Thank you. And thanks for all your work, Barkha.